right? So as I go through these slides, no disclosures, no financial relationships to disclose. I do have a couple of clinical trials currently ongoing that relate to this presentation, but they're not industry funded. It's the funding is to the National Institutes on Drug Abuse. So I feel comfortable with that. And yeah, so we're gonna go right into the different formulations of buprenorphine that are out there, right? And then I want to go a little bit into kind of what we call home-based induction or home initiation of buprenorphine, which is what most people are doing right now, right? And then I'm gonna actually go into different strategies for starting people on buprenorphine when they've been using fentanyl, and then a couple of slides on sort of diversion management and duration of treatment, questions that come up a lot. So I try to incorporate some of those questions that come up pretty routinely in our echo clinics. So I'll start with formulations, right? So new ones are coming out all the time, right? So this is like a little bit of a, I guess a little, I don't know, I guess a graph that talks about all the different formulations that are here. I think the first thing that we can say is that, there are formulations that include a little bit of naloxone to them as a way to reduce diversion. And there's buprenorphine monoproduct, which is buprenorphine alone. So I think that's the first big difference between the two, right? So focusing on the buprenorphine monoproduct, that's buprenorphine alone, no naloxone added to it, there is a sublingual formulation, a tablet, comes as generic and also comes under the brand name Subutex. And again, I am using brand name here, and I will a couple of times, but again, that's I don't have any financial disclosures. It's because our patients are going to be using them. So there's also the brand name Subutex, but it also comes as a generic tablet, 2 milligrams and 8 milligrams. In my practice, and I think that's fairly consistent with all of us here at the UNM, in the UNM addictions team, we use this generic monoproduct, buprenorphine monoproduct, in individuals during pregnancy. But rarely do we use it outside of pregnancy, because the idea is that because these tablets do not have naloxone added to it, at least in theory, there is a higher potential for someone misusing the prescribed medication through injection, because it's more reinforcing and it's less likely to lead to precipitated withdrawals. So in the spirit of minimizing diversion, we tend not to use the buprenorphine monoproduct unless the individual is pregnant, or I suppose the individual has a documented allergy to naloxone generally. So that's one. There's also a buprenorphine implant that remains approved by the FDA, but it's not on the market anymore because there was no market for it. No one was using it. And there were a couple of us here who had completed the training to be able to use it. But I can tell you that I never had the chance to do it even once. And neither did Dr. Romo, who was also trained in it, because no one was interested. And it was basically an implant that gets placed in the upper arm and replaced every 6 months. And there was really no market for it, so the medication is not even on the market. There is a monthly injection called a Sublocade. It's a subcutaneous injection in the abdomen that is available. And I think at our clinic, we currently have maybe 20 or so patients on it. I think, so those are the main mono products. There is also a new injection that's not on the market yet, but will be, I think, within the year in 2023. And that will be under the brand name Brixadi. It's also a subcutaneous injection. I think there are a couple of big advantages that injection has over the existing injection. One is that it does not have to be refrigerated. So storage is a lot easier. The Sublocade does need to be refrigerated. The second is that the Brixadi injection is actually a lot less painful. It's not painful versus the Sublocade injection, which is quite painful despite being subcutaneous, because the thought is that the medication sort of reacts with the subcutaneous fat and causes a fairly painful localized reaction. The Brixadi, the new injection coming out, is not painful. And the third is that you can see that the Sublocade injection comes in 2 doses, 300 and 100. The idea, or at least the product insert, states that the first 2 injections are 300 milligrams each. They're a month apart. And then you try to drop down to 100 milligrams. what we're finding and what many people around the country are finding is that as soon as you drop people down to 100 milligram injection, they're experiencing withdrawals and cravings. So I can tell you that at our clinic, most people just wind up staying at the 300. The new injection that's not on the market yet, it comes in multiple different formulations, 4 different weekly formulations and 3 different monthly dosages. So it allows for a lot more individualization of doses. I will give sort of a disclosure or whatever that we do have currently a clinical trial ongoing that several of us are on, including Dr. Jacobson and Dr. Warwick. But it's not funded through the industry. It's a NIDA funded study where one of the conditions we're looking at is this new injection that's not yet on the market. So we'll know more. And I think it will be on the market probably within the year. For most of our patients, we wind up using buprenorphine with naloxone, right? And again, the naloxone is added primarily to minimize misuse through parenteral route. Naloxone, if someone takes it as prescribed, which is sublingually or buccally, isn't really active. It's not adding to the medication profile, but if someone decides to inject the medication, it becomes active. And that's really throws people potentially into withdrawals if they've been using other illicit opioids. So that's the idea. There are many different formulations available. There's generic films, there's brand name films, which is called Suboxone. There's generic tablets. There's another brand name tablet named Subzolve. There's a buccal formulation, which is used more for the treatment of individuals with pain. I can tell you that usually what determines which one we pick, they're all equally efficacious, is what is the patient's insurance likely to cover and what's more likely to be stocked in the pharmacy, which I know many of you can attest to can be a major challenge, right? Depending on which part of the state you're practicing in. At least here in Albuquerque, what I wind up prescribing the most is generic sublingual films of 2 milligrams of buprenorphine combined with 0.5 milligram of naloxone if someone's on a very low dose or during the initiation, or the 8 milligram/2 milligram films for patients who are on maintenance, because I find that that's usually covered by insurance and more likely to be found, but they're all equally efficacious, right? So that's just a little bit about formulations. I think patient preference matters, right? But in practice, a lot of times, I wind up picking also based again upon availability and access to the medication. So talking about formulations, I think the official recommendation remains that the combination medicine should be used for treatment of opioid dependence, opioid use disorder. The mono product I use, as I mentioned, during pregnancy, if someone has a documented allergy to naloxone, and something ethically that comes up. A patient says they don't have insurance, maybe they're self-pay, they can't afford, or maybe they have private insurance that does not cover the combination medicine. And they say, can you just prescribe me the mono product, buprenorphine alone, which tends to be cheaper? And I think it's an ethical discussion to be had and also a patient-centered discussion to be had, where certainly we want them to be able to access treatment. I think access to care, at least from where I'm coming, is sort of the number one priority. And if the only thing the patient's going to be able to access is buprenorphine alone, I'm likely going to go for that. But I'm also going to have that discussion with the patient, a very open discussion that this does create a risk for diversion. And we don't want that. We want to be able to work with you. We want to be able to help you. So perhaps setting in place an individualized monitoring plan, that if I'm prescribing the buprenorphine mono product, perhaps we prescribe shorter prescriptions, or maybe do more closer monitoring, including monitoring for buprenorphine metabolites and random callbacks. Another time, interestingly, this buprenorphine mono product discussion comes up is during initiation. Increasingly, we're finding patients who are just scared. I try to educate them that it doesn't really matter if you're initiating with the combination medicine or buprenorphine alone, but they are so scared because of the message maybe they received before. Can we please start with the buprenorphine mono product? I generally say that's fine. It's only for a few days. If that's what's going to allow the patient to get on the medication, I'm okay with it. But I have the discussion that once you got on buprenorphine, we'll just switch you over to the combination medicine, right? We've talked about naloxone being included primarily as a way to reduce misuse. We've talked about the formulation and the mono product. Film or tablet, again, both work about equally well. But, I think at least the idea is that film dissolves quicker, which might be more convenient for the patient. And films also come individually wrapped. So this is purely theoretical. That's why I put a question mark next to it. Does that lead to possibly reduced diversion because you can track it through 48-hour callbacks better? I don't think there is any good data on it, right? But I generally wind up prescribing the films because, again, they're absorbed quicker and generally they're available and covered by insurance. I think there is this idea that I hear a lot that why don't we just put everyone on the injectable medicine? Implant is out, it's not on the market. I come across this quite a bit because that's driven by the desire to minimize diversion. That if you're just injecting someone, right, then you don't have to worry about diversion. I push back on that a little bit for a few reasons. One is that patient choice matters, right? Some patients want injectable, and that's great. But we have many patients who don't want the monthly injection for a variety of reasons. Maybe they just don't like injections. It is painful, as I mentioned. Or maybe they like the structure of taking the medicine daily, and they prefer the sublingual. I think that's an important thing to take into consideration. Also, I think it's important to recognize that the injection is a lot more costly. There's a closed distribution system, so patient access to injection is harder, right? And there is less clinical experience and fewer treatment choices, fewer dosing choices. All of those, I think, favor the self-administered sublingual formulations, right? Cost is less, it's more readily available. There are many more doses and formulations available, and there are no head-to-head comparisons as of today. So the sublingual remains the current standard of care. When have I used the injectable? Patient preference. Certainly, we have patients who want that. Second time is that sometimes we've had patients who we put on injectable to reduce risk. What do I mean by that? I can think of a vivid example in which a patient was at risk of losing their housing if they were taking buprenorphine because the person or the group, agency, whatever, with whom they were staying were opposed to buprenorphine. They saw it as another, quote unquote, another drug. You cannot live here if you're on buprenorphine. The patient needed housing, the patient needed buprenorphine. So we made a decision together to switch the patient to the injectable formulation. And that allowed the patient to stay on buprenorphine and to remain housed, right, securely housed. And the third thing is, if there is significant concerns for diversion, you put in practice more diversion control mechanisms, but the diversion risk remains, then for those patients, perhaps what we can offer is saying, listen, it's not really safe for me right now. I don't feel comfortable continuing to prescribe you buprenorphine because I don't know if you're receiving the medicine you need. But what we can offer you is treatment with this injectable formulation, right? So that becomes another option. Now, going to the second big piece I want to cover is initiations, right? First thing is home initiations. When buprenorphine first came out, everyone was doing only office-based initiations, right? Under direct observation. But as early as 2007, primary care providers were starting to do home initiations where patients are sent to home with their prescriptions for buprenorphine, some educations, and you start on your own. And turns out that home initiations are just as safe and just as effective as directly observed office initiations. And this was finally published in 2017, this 7-year data, where outcomes are comparable. So really at this point in 2022, as Dr. Scott Johnson, who's one of our primary care colleagues here in town, likes to say, home initiations are the standard of care. That is the norm. We generally always do home initiations, except, there are some people who may have low tolerance. So you want to be more safe. Or if patients are transitioning from methadone, which can be a tricky transition, or if there are significant cognitive impairments or untreated psychiatric conditions, where again, you want to make sure patients do it appropriately, do it right, do it safely. And then we sometimes have fear as a factor, right? Patients who are so afraid of it I feel more comfortable if I'm in a provider's office, and we try to honor that. But other than that, we will generally do home initiations for most patients. I've included, and this is largely for reference, some slides. Everyone does it a little bit differently, but the key part here is education. We provide education to the patient. I really stress that you want to wait until you're withdrawing before you take your first dose of buprenorphine. We often tell them, you want to be feeling withdrawals in at least 3 different body symptoms, right? So GI stuff, nausea and vomiting, maybe joint aches, and maybe rhinorrhea, right? So at least 3 different systems you want to be feeling withdrawals. But more than that, I often send them home with a withdrawal scale. This is the SOUS scale, which is a subjective opioid withdrawal scale, which is meant to be self-administered, or even the COWS. And if you're using the SOUS, I use a target score of at least 17. The scoring is a little bit different compared to the COWS. And if you send them home with the COWS, use a target of about 13 to 15, about 13 or so. And then you start. You send them home with a couple of days. So I might send them home with a script for, 4 films of 8 milligrams of buprenorphine / 2 milligrams of naloxone. Tell them once you're in enough withdrawals, start with 4 milligrams and redose every couple of hours. Sorry, I've had the worst allergies since yesterday, and it's not a cold. I apologize. I'm talking too much. And you start with 4 milligram doses. I tell them to keep redosing until you feel better, or until you get to about 12 or 16 milligrams on day 1. Call the clinic. If there are problems, we check in with them on day 2. Take the total of day 1 dose in the morning and take additional 4 milligram doses until comfortable, or until a maximum of 16 is reached. And that's it. They're at 16, which is that initial target. So you can get most people there in a day or 2, right? And this is the magic numbers I tell patients. With short-acting opioids, we tell them to wait about 12 hours. Most long-acting opioids about 24 hours. And with methadone, usually about 36 to 48 hours. If they're transitioning from methadone, that's a tricky process. We first have to bring them down to 40 milligrams or less for at least a week. Then they generally go without methadone for about 48 hours, during which we give them comfort medications, and then we start low and build up. And I often will do this directly observed in the office, given how often this is. If precipitated withdrawals do happen, I think precipitated withdrawals are best prevented than managed. It's a lot easier. So I tell patients, be honest with us, be honest with yourself, and make sure you're truly withdrawing before you start taking the buprenorphine. But if precipitated withdrawals do happen, in general, what we tell them is to take more buprenorphine. Withdrawal is withdrawal is withdrawal, and more buprenorphine will help bring patients out of withdrawals. And in addition to more buprenorphine, we also give them comfort medications for symptomatic management. That brings me a little bit to what is happening with high potency synthetic opioids. We have a whole other talk that we're doing on it, where we go into this in a lot more detail, but I would feel really remiss if I did not address this in this talk, because that's all we're seeing. We're seeing people using high potency synthetic opioids, right? Fentanyl. And we're seeing people go into withdrawals when they take the first dose of Suboxone. And everyone's saying, I had precipitated withdrawals, and that's why I don't want to take Suboxone again, right? What do I think is happening? I think there is actually 2 different things I'm seeing. One is that I'm seeing true precipitated withdrawals in people who are using illicit fentanyl. We know that illicit fentanyl tends to build in tissue, release gradually, so it takes longer for those withdrawal symptoms to kick in. So sometimes patients are so anxious about withdrawals, right, that they wind up taking the Suboxone too soon and experiencing precipitated withdrawals. I think we're also seeing people going to precipitated withdrawals because they're co-using illicit fentanyl and methamphetamine. So I've seen patients where if you just give them the COW score, it looks like they're withdrawing because their pupils are dilated and they're anxious and they're restless and they're scratching. But maybe that's happening because they're intoxicated on methamphetamine, and that's falsely driving up that COW scale. So I think that carefully talking to the patient first and taking into account that co-use of methamphetamine can help minimize that, right? The second thing that's happening is people are waiting too long. And what I mean by that is that, again, a vivid patient example. I saw a patient probably about 2 months ago who said they had precipitated withdrawals on Suboxone, so they never wanted to take it again. So I told them what happened. So the patient saw a provider in the community. The provider told them how to start buprenorphine, and they used like what we learned in the buprenorphine course. So wait until you're in moderate withdrawals, then start with 2 or 4 milligrams of buprenorphine, wait 2 hours, then take another 2 or 4 milligrams. Well, the patient waited until they were in severe withdrawal. So their cow scale, I think, was like 25. Then they took 2 milligrams of buprenorphine. It did nothing. 2 hours later, they took 2 or 4 milligrams more, which simply was not enough. So it wasn't true precipitated withdrawals. It was prolonged withdrawals because we were not aggressive enough with buprenorphine dosing, right? So people are starting to look at different ways to start buprenorphine in people who are using illicit fentanyl. One that we're using very commonly, right, in the outpatient setting are these microdose initiations, where we tell people that it's okay for them to keep taking their illicit fentanyl, their illicit opioids. And as they're doing it, we start adding in tiny amounts of buprenorphine, raising the dose. You can see how low the doses are. We start at 0.25 milligrams. Day 2 going to 0.2 milligrams twice a day, and slowly increasing it. So the idea is that each day, the buprenorphine, because of its higher binding affinity at the mu-opioid receptor, displaces a little bit of the fentanyl and takes its place. So over the course of about 7 days, although the patient is taking fentanyl, what's really occupying those mu-opioid receptor at this point is buprenorphine. And after about 7 days, we have them jump off of the fentanyl. Stop using fentanyl. We'll give you comfort medications. And day 8, go up to 16 milligrams of buprenorphine. And if needed, as often is, going up to 24 a couple of days later, right? Finally, we're also doing, we talked about this a little bit, the macrodose approach. So this I'm using if the patient already comes to us in withdrawals. So if the patient has already stopped the fentanyl and they're already withdrawal, we're more aggressive. So very often, and I know Dr. Gadomski, you do this quite a bit, is building up from 8 to 16 to 24 milligrams within a couple of hours. So very quickly building up the dose to get them over the hump. I think the macrodose approach we're using really most commonly when someone is already in withdrawals. And the microdose we're using in an outpatient setting if the patient is not withdrawing and they're very worried about withdrawals, which prevents them from stopping the use of buprenorphine. This is a very interesting study which is now published by Mariani's group in New York, where they actually did, these were all people using illicit fentanyl. So on day 1, they built them up to 24 milligrams of buprenorphine sublingually, and then they gave them the 300 milligram subcutaneous injection of long-acting buprenorphine, which achieves even higher plasma levels. And most people in this series, well, all the patients in this series tolerated that well. So kind of a very aggressive way to approach the macrodose initiation of buprenorphine. I suspect we're going to see this more and more as we move forward. A couple of other thoughts. I know we're over time. A couple of other thoughts is that for maintenance dosing, generally, FDA maximum is 32. Most insurances will cover up to 24 milligrams. That being said, in the era of illicit fentanyl, many of our patients are needing 32. And that's okay. Just document, right, that the patient had withdrawals when we went down to 24. And generally, we match the duration of prescription to how the patient is doing. We will often start with weekly scripts at each visit for about 4 cycles, then go to every 2-week scripts for 2 or 4 cycles, then monthly, and for patients who are functioning well, we also add in refills, right? I think the most refills I've done in my practice has been 2, so monthly plus 2 refills. But I think legally you can go up to 5 refills because buprenorphine is Schedule 3. Diversion management, I think it's good to have a universal clinic policy. So generally things like urine drug screens, of course, PDMP monitoring, which is law, right, which is legally required. Things like 48-hour callbacks for more higher risk patients, and ensuring safe storage, including lock boxes. And finally, gonna end here, I went over that quickly, is withdrawal. How long should maintenance be? We don't have great data. We actually have a trial going on right now, which is a multi-site study that's hoping to get to a point where we can predict which patients may be able to successfully taper off of maintenance treatment, and can we and how might we best achieve it, right? But that the data is still at least 3-4 years away. We don't have that data right now. All we have is data that shows that even people who have done well on buprenorphine or methadone, for that matter, for up to 16 weeks, once they're tapered off, just within weeks, majority of them, 90% plus, will return to using illicit opioids. And some of them will die, and most of them will not stay in treatment. So the data is very grim, right? So generally what we tell them, and just what this slide is showing here, is that simply by increasing how long you taper them for, outcomes don't really change. So tapers themselves in general are associated with pretty poor outcome, and the risk of overdose clearly goes up. There's multiple studies. So we tell patients, don't worry about tapering now. We caution patients from tapering too early in treatment. And what I generally tell them is, early in treatment, I'll make a list of functional goals. What are the things you want to achieve as you're being treated? Periodically revisit it. And this is generally the message I give, that if you want to withdraw, of course, we'll support you in it, but I would recommend that you do it once your life is stable. You met those goals that you set at the onset of treatment. Your social networks are more stable, and we do it at your own pace, gradually. And I would encourage them to remain engaged in treatment, therapy, 12-step groups as they're tapering. And lastly, I consider depot naltrexone, also known as Vivitrol, upon completion of withdrawal as a safety net if the patient is having a lot of anxiety about being medication-free. And with this strategy, we've actually had many patients who've been able to successfully taper off. What I don't do is force patients or pressure patients into tapering. And what I do is caution them from tapering too early. That's generally the clinical approach right now. So I will stop here. I kept it to 30 minutes, but it's still over time. So I apologize about it. Thank you. Hope that was somewhat useful.
Very useful. Thanks, Dr. Bhatt.